Subhash Chandra, a very senior and erudite cardiologist with more than 25 years of experience. It's been my personal privilege to have interacted with him at a couple of forums. Very senior cardiologist. Sir has been the faculty at All India Institute of Medical Sciences, and apart from the routine conventional acute cardiology and clinical cardiology, he is very interested in valvular heart disease and adult congenital birth defects, which doesn't seem to be, very much of interest with other senior cardiologists of his stature. And sir has been the recipient of the Sujoy B. Roy Award as the Young Investigator Award of CSI, has received the Colonel K.L. Chopra Award from CSI for research in cardiology, has trained numerous DM and DNB students, was the former director of cardiology at Fortis Escorts Heart Institute, more than 100 publications to his credit in national and international journals, and with significant number of firsts like alcohol septal ablation in Hokum, pericardial window creation using the Inouye balloon technique, retrograde mitral valvotomy technique, crosswire on chronic total effusion, valvular balloon dilatation of all kinds. And he was a faculty for a fair number of years at the All India Institute, and he was also the personal physician to the Honorable Prime Minister of India, Sri P.V. Narasimha Rao, from 1994 to 1998. And he has had significant presence at the international forums like the TCT and the Euro-PCR, where he is always engaged in very significant meaningful discussions and has been the chair and speakers at both these forums. And before joining BLK as the chairman of cardiology, he was there at Fortis Escorts Institute, and prior to that at the Narendra Mohan Heart Center, and he was the director cardiac cath lab there. And needless to say, he is a fantastic speaker, excellent command over the subject, and very highly regarded in cardiology circles. And one thing I may add, he is a brilliant singer also. So it's my pleasure to present Dr. Subhash Chandra. Sir, the stage is all yours.
Thank you, Dr. Sen Gupta. That was really humbling. You have spoken so many words to introduce me. Well, it's always a proud privilege to be part of this forum, the South Delhi Physician Forum, and which constitutes some of the very esteemed and senior members. And Dr. Chauhan in particular was the one who took this initiative, and on behalf of the society, he proposed that let's hear on the calcium channel blockers, which emerge as part and parcel of the most of the antihypertensive therapies today. And Dr. Sen Gupta is no less in terms of the academic pursuits, and I have had a chance to interact with him on various forums. I mean, his level of knowledge is commendable. So, without much ado, and my apologies for coming on this platform, which is WebEx, for some reason, but I'll definitely come back next time on a Zoom so that we can gather a larger audience on this webinar. So, with that, sir, let's start. Dr. Sen Gupta has already alluded to a lot of sites of the calcium blockers, the receptors and all. Well, I may not go in much detail on those aspects. I would suffice to say that calcium channel blocker being a potent vasodilator, how does it constitute the part and parcel of most of the antihypertensive regimens, and what is its role in terms of reducing target organ damage and improving mortality of hypertension. But the biggest challenge about hypertension is first to understand the magnitude of problem in our country, and then what is the diagnostic dilemma about the hypertension detection, and then we come to the real management part. So the India story is that about 40% in urban areas and about half of them, or less than that, in rural areas suffer from hypertension in our country. Both man and woman, they replicate what is the global figure of hypertension prevalence in people of more than 25 years of age. We know that these are the target organs for hypertension, and it would be that the hypertension is responsible for almost 57% of all stroke deaths, both thrombotic and hemorrhagic. It accounts for almost 60% cases of chronic kidney disease and 24% of coronary artery disease deaths. They eventually both of them combined together would constitute the biggest cause of heart failure in our country. Coming to the diagnosis and management part of hypertension, the challenges faced by doctors are that what are the best diagnostic tools to rely today? Is it the office blood pressure or the ambulatory blood pressure monitoring or the home monitored pressure, and how should we use them and how should we tap them to diagnose hypertension in our population? What should be the best way to control hypertension? Should we always start with the monotherapy or should have combination therapy right from the word go so as to reduce the target organ damage in the long run? And what is the place of patient channel blockers? Do they still rule supreme or taken from the various armamentarium of the antihypertensive medications? Where do they stand in the overall list? There's a huge discrepancy in clinic blood pressure measurements and home blood pressure monitoring. And you would recall the SPRINT trial, which gave us the maxim that the lower is better, which perhaps was not true given the J-curve hypothesis that if you reduce blood pressure much low below 120 and 80, it leads to increase in the complications of target organ damage. So therefore, the optimal blood pressure values have emerged, and we are aware of the last year's 2020 International Society of Hypertension recommendations also. I would also touch upon that. So the diagnosis of blood pressure is a real challenge as of today, and let us see what are the various aspects of looking at the tools of the hypertension management reduction. There are almost 42% patients which are not hypertensive, but they are misdiagnosed as white-collar hypertension the moment they visit hospital or a doctor. And almost equal number or large are missed as diagnosis of hypertension or what we call as a masked hypertension. And this is the most bothersome entity for us because this is one entity which, if it remains masked, would lead to tremendous target organ damage in the long run. So out of this 42%, 24% is the misdiagnosed because of white coat hypertension, and 18% is the missed diagnosis of hypertension, what we call the masked hypertension. This chart is very important. As you see, if you look at the manually measured office blood pressure, as on the bottom, the normotensive constitute any person whose blood pressure is less than 140. And if we add the ambulatory blood pressure to this category, then what we see is that the true hypertension emerges as both by ambulatory and manual blood pressure, where the manual blood pressure, the blood pressure in excess of 140, and ambulatory, the blood pressure is more than 135, and that's the large chunk. But there are two major large chunks here that on a manual office blood pressure, a normotensive visiting a doctor would be diagnosed as hypertensive called as white coat hypertension. On the other hand, an ambulatory blood pressure is performed in a person over and above the office blood pressure, you would realize that a large chunk emerges as a masked hypertension, which was found to be normotensive in office blood pressure, but on ambulatory blood pressure reading, he was found to be hypertensive. And you know the various paras of analyzing ambulatory blood pressure. That would mean the non-dipper. Any person whose blood pressure failed to dip 10 to 20% during sleep is a hypertensive. Or a reverse dipper, the one whose blood pressure rises during the sleep, like an OSA patient. These are truly hypertensive, and they are the masked hypertension patients. And they perhaps have the biggest toll of the target organ damage of undetected hypertension, as you see in the last column as masked hypertension. So the 70% hypertensive patients are uncontrolled despite treatment. This is another glaring fact which my colleagues here on this platform would agree, that if you see 7 patients, 3 are unaware, 1 is aware but he's not optimally treated, 2 are treated and yet the medication is not to mark, and just 1 person is controlled below the target values of hypertension. The right management of hypertension starts with the correct diagnosis of hypertension, and these are readings which I showed you in one of these slides, that office BP of more than 140/90, ambulatory BP 24 average of 130/80, daytime average 135, nighttime of more than 120, and home monitoring of 135/85 is what constitutes the diagnosis of hypertension. We must also realize that today there's a lot of emphasis on home monitored blood pressure, because that is one blood pressure which, if patients taught nicely, would clearly give you the morning evening averages of a week's blood pressure value and can arrive at a diagnosis of true hypertension. A 1 week's home monitored blood pressure readings are equivalent to 124-hour cycle of ambulatory blood pressure monitoring. That also we must know. So the ideal way of blood pressure measurement, accurate diagnosis begins with accurate measurement, and if possible, the available diagnosis of hypertension be confirmed by out-of-office measurement and not rely on the office measurements. So home blood pressure and ambulatory blood pressure are the preferred out-of-office methods of diagnosis. And if we look at the target organ damage in the form of the LV hypertrophy and albumin excretion ratio, which is a marker of kidney damage because of uncontrolled hypertension, you would realize the office blood pressure at best is capturing just about 0.3 to 0.4% of population of LVH and 0.3 to 0.4 on the albumin excretion. Whereas if you track home monitored blood pressure, ambulatory blood pressure, this figure goes much higher. So those are the pressure techniques which should be employed more and more in diagnosing hypertension. So this is what we have been saying in the last slides, that home monitored pressures of more than 135/85, which is equivalent to office pressure of 140/90. Home monitored pressure provides more reproducible blood pressure data because the patients relax and he has completely learned the technique of measuring blood pressure at home, especially with the oscillometric or computerized blood pressure monitoring instruments, and that is correlated with the left ventricular hypertrophy, and it is directly linked to the morbidity and mortality of hypertension. So this is a word about the 2020 International Society of Hypertension Global Guidelines. The key points of these guidelines are that the blood pressure control is divided into essential and optimal control. And to devise these guidelines, the experts were roped in from lower income, middle income group countries as well as high income group countries. So far in past 2 decades, what has happened is that majority of our guidelines are framed on experts who reside or who practice in higher income group countries, and we translate them in our country as a middle or low income group country, and that's the biggest tragedy. So the key feature of this ISH guideline is that a blood pressure which is controlled to a level is the essential. That means any person whose blood pressure is over at 140 and 80 will be an essential. The optimal will be the ideal target, and that is always strived to be achieved in the practice. One should start treatment with a single pill. However, starting with a single pill which has combination of 2 or 3 molecules would ensure compliance and would go a long way in reducing the target organ damage in the population. The wider out-of-office blood pressure measurements are emphasized here, and the lower BP targets have been propounded in these newer guidelines. So these are the Indian guidelines which almost match with what I have shown you on the office or self-monitored home monitoring and ambulatory BP pressure, and these are the readings which most of us rely upon. The advantages of home monitored blood pressure I've already told you, and it ensures compliance and participation management also, because the patient is aware that how do he has to titrate his medication in order to bring blood pressure within the optimal or the essential zone to prevent target organ damage. This is how the home monitored and 24-hour blood pressure differs, and I would not go into detail of this, but suffice to say that 3 to 7 days monitoring in the morning and 2 measurements of each occasion of 5 minutes sitting and 1 minute between the measurements is what is required for the blood pressure monitoring on the home monitored blood pressure. Whereas in 24-hour cycles, 24 hours monitoring at 15 to 30 minutes interval during daytime and nighttime, and at least 20 valid daytime and 7 nighttime BP readings are mandatory to interpret the ambulatory pressure. There are apprehensions or objections to the ambulatory pressure that during sleep, if a person's arm is pressed every half an hour, it could always have a disturbed sleep, and that will have implications on the overall blood pressure value of the population. Now, so home monitored pressure is always a better predictor. I need not re-emphasize it here. Coming to the advantages of home monitored pressure, that this is more reliable, more reproducible, more acceptable and tolerable, and more repeatable. That is how it is compared with the ambulatory pressure or the office blood pressure. And the tools for lifestyle modifications are more better adapted if a person is able to monitor his blood pressure at home. The daily activity interference are more applicable in this population. Compliance, adherence, awareness, active participation, motivation, doctor-patient, everything is improved by the home monitored blood pressure technique. And today it is a norm that one must prescribe the best and calibrated instruments to your patients to monitor the blood pressure at home, and one must teach them that's how the blood pressure monitored and what time it should be monitored, and keep a chart of these blood pressure monitoring systems. Now, once the diagnosis is correct, the next step is about treatment. The treatment largely depends on the comorbidities or compelling indications of these patients, and in this we must factor in the additional risk factors or the organ damage or the previously existing disease in this population. And based on which one can always change the category of hypertension from grade 1 to grade 2 or to grade 3, and accordingly one can choose the antihypertensive medications, which could range from 2 to 3 to 4, and a combination of these in a single pill. This is the sprint data which said the lower the better, but here the problem was that majority of the time the blood pressure of these patients were measured in an unmonitored manner. And as I said in the previous slide, the unmonitored blood pressures are always lower than the actual office blood pressure, and that is what resulted into the improved outcome in the sprint population with the use of antihypertensive medications. But that was not the case because the technique by which blood pressure was measured in this trial was fallacious. The sprint criteria of measuring blood pressure would not apply to any person who has a heart failure or has a recent myocardial infarction or currently not receiving the beta blockers or institutional elderly, diabetic, prior stroke, poor kidney function, patient unwilling or unable to adhere to multiple medications, the standing systolic pressure less than 110, inability to measure systolic pressure accurately, and known other secondary causes of hypertension like coarctation or pheochromocytoma. So the ideal characteristic antihypertensive drug is that there should be an evidence-based relation of morbidity mortality reduction. There should preferably be once daily regimen which provides 24 hours blood pressure control. That would mean the pharmacokinetic of the drug should be such that the test-to-trough ratio is the minimum, and therefore it ensures a 24 hours control. There's always a debate that whether one should use this blood pressure medication in the morning or in the evening so as to take care of the morning surge of blood pressure. Well, there's an ongoing trial by the name of TIME, the results of which are likely to come at the end of this year, and that would give the clear path as to when should the antihypertensive medication be given. The treatment should be affordable, cost-effective, and it should be well tolerated, and the benefit of the use of medication should be applied to the population at large. So such are the requirements of the ideal antihypertensive medication, and it will be logical to block multiple pathways, and therefore one should try and take help of multiple drugs. But let's look at the data in past, and you would appreciate the majority of data which I'm showing here, all hot trials, or the hot trial, or life trial. The majority of trials have relied heavily on a calcium blocker in their overall protocols. Well, life was a trial on losartan, but all hot and hot trials used calcium blockers. So the aggregate of available data suggests that at least 75% of patients require combination therapy to achieve contemporary blood pressure targets. And if you look at these trials, you would realize that the majority of trials have used and taken help of more than 2 or 3 or sometimes 4 drugs to achieve the blood pressure control in this. And calcium blocker has been the biggest player in majority of these trials. Single pill combination is always preferred, as I said, because of the compliance, and the latest guidelines, be 2018 ESH guidelines or the 2020 International Society of Hypertension guidelines, all of them propound that calcium blocker, ACE or ARB, and a diuretic is the ideal way to go as to achieve the optimal or essential blood pressure. So 2-drug combination, single pill strategy, having a calcium blocker, ACE, ARB, and a thiazide-like diuretic is the way. This is the JNC7 chart, and all of us know about this. I would not go to the busy chart, but suffice to say that once you have moved on from lifestyle modification, the targets of blood pressure, which is 130 and 80 or less, and no less than 120 and 80, should be achieved by a combination of calcium blocker, ACE-ARB and a thiazide at the outset. If not controlled, then one can add on an alpha blocker or beta blocker in patients who underline coronary artery disease or heart failure, and that is the way to control blood pressure in these patients. So this is the target as per the Canadian guidelines, and you would see the calcium blocker emerges as one of the strongest choice here. Now, I would also take you through some of the trials which have amply showed that by using calcium blocker, it is possible to reduce mortality of hypertension and control blood pressure to the target value. So the combination therapy, especially in a single pill, is the one which rules the world today, and that is the way to go forward to control blood pressure. 2 or 3 drops combined in an antihypertensive medication. And this is the ISS 2020 treatment guidelines, which was said the essentials could be achieved not only by lifestyle modification, but going on to take help from calcium blocker, beta blocker, and the thiazide-like diuretics. All her trials, 60% those whose blood pressure comes to less than 140/90 receive 2 or more agents. These guidelines do suggest that use of thiazide-like diuretics such as chlorthalidone is the way to go further. And the MR-FIT, CHEF trial, all her trials have all relied heavily on the use of diuretics as well as calcium blocker in their use. And there's also a theory that if you combine calcium blockers with an ACE inhibitor and diuretic, it is actually possible to counteract some of the ill effects or the adverse effects of these drugs. Say, for example, ACE inhibitor could reduce the peripheral edema, which is classically observed calcium blockers, and so it can counteract microcirculatory effect of amlodipine. Similarly, thiazide-like diuretics or indapamide could also add up to reduction of edema with this molecule. The ASCOT trial, as you recall, was a major trial of 20,000 patients where amlodipine along with one of the ACE inhibitor perindopril was used, and there was a proven mortality benefit by virtue of having a very potent antihypertensive in a calcium blocker. And this was compared to etinolol where amlodipine perindopril combination emerged as a winner. The legacy effect, now published at 16 years follow-up, continues to be there with the antihypertensive treatment. Advanced trial, which is another trial where the calcium blocker was used along with perindopril indapamide, especially in the stroke patients, and it did result into cardiovascular and cerebrovascular incidence being lowered by this combination. The new data for LV hypertrophy regression has emerged with the help of calcium blockers, and therefore calcium blockers still rule the world as far as the control of hypertension is concerned, because it does reduce the target organ damage. This chart I've already shown that one has to start with a calcium blocker and a combination of ACE-ARB diuretic, and if not, then resistant hypertension could be managed by adding spironolactone, alpha blocker, beta blocker, or any other potent drug. This was all her trial in which 33,000 patients with one CSD risk factor along with hypertension were recruited, and the calcium blocker and ACE inhibitor and diuretics were compared, and this has clearly shown that at the end of 5 years, the amlodipine was emerging as a clear winner in terms of reducing mortality in these patients. Value trials as Valsartan was compared with a calcium blocker in 15,000 population. There again, calcium blocker cohort was showing clear better control of blood pressure as well as the mortality reduction. The accomplished trial, which was dedicated to the renal protection in patients who had underlying CKD or dysfunction, that aged more than 65 years or so, and here the comparison of amlodipine versus hydrochlorothiazide has shown that using amlodipine results into better control of blood pressure in this population and can halt progression of CKD in the renal population, as was shown in this graph, where a combination of amlodipine with benaziril resulted into better primary events compared to the benaziril plus hydrochlorothiazide. So calcium blocker, as you could see, is the way to go forward for the control of hypertension. Camrose is a trial where calcium blockers not only have the benefits for hypertension control, but also the atherosclerotic regression and coronary artery disease. So when amlodipine was used here along with enalapril and other molecules, it did result into mortality benefits in CV event reduction and hospitalizations by controlling blood pressure and regressing atherosclerosis, as was assessed on the intravascular ultrasound. So with that, I will stop it here, I apologize that I could not distinguish between various available calcium blockers, like Dr. Sen Gupta said, Rhodocin, Cilintine, Naltrexone. Well, leave that open for discussion. For me, most of them have equivalent action, and I don't see much difference in this profile, especially the people. So thank you very much for attention. So, Dr. Sengupta, I urge that we have a discussion now on this.
Yeah.
I have a presentation on OCT which I can take after the discussion with the hypertension. That's about 10 minutes presentation. I just want to apprise that the current method of doing precision angioplasty, how have evolved?
Sure, sir. Sure, sir. Please go ahead, and we'll take the questions. And actually, I mean, thank you very much for the brilliant lecture as usual, sir. I mean, the way you speak is phenomenal, alluding to all the guidelines and how the relevance of and the importance of clinic and ambulatory blood pressure monitoring is there, and how stringently they should be adhered to in terms of protocol, what we have to do. Actually, the brief given to me was that by both Abbott and the PFI was that the topic would be on comparison of calcium channel blockers. So that is why I took that path, and especially with respect to the present generation and whether the older ones were still holding core.
I'd love to hear it from you, sir. Maybe a 5 minutes brief on key advantages.
No, that's absolutely fine, sir. Yeah, please go ahead, sir. Please go ahead.
So, I will just apprise you about the latest technologies in angioplasty which we do day in and out.
Sure, sir.
Tools which are the physiological tools like FFR and the imaging tools like intravascular ultrasound, which was there for a long time, and now an OCT, which is a kind of color television view of the inside of the coronary artery, and how it can change your practice and optimize results of current day angioplasty, which will have a lasting value as compared to the bypass surgery. So I want to burst this common perception with the public that angioplasty is inferior art of doing treating patients coronary artery disease. Let's see how it helps us. So this is a light lab initiative which was there in America, in which a large number of centers were roped in, and this was called as an MLD Max. And MLD Max has 6 aspects to the use of OCT in a common day practice. Imagine if, apart from angiography, if you are able to insert a camera inside your coronary artery and you can actually see it from inside, that what lies in the lining of the coronary artery. Is it a smooth lining or is it a rough lining? Does it have underlying calcium which will impede the expansion of my stent? Or are we leaving behind any dissections? Or are we leaving behind the unexpanded stents, which is a precursor for stent thrombosis, which is a very life-threatening complication, or even long-term restenosis. So all that aspects can be fixed then and there when we're leaving the cath lab after doing an angioplasty, and that's only possible by inserting a camera inside the coronary artery and making sure that all the aspects which I narrated have been best taken care. So this was a global Pan-American study, and here what was seen that close to 2,200 diagnostic intervention procedures across 604 workflow PCIs, and they dwell upon these aspects: the pre-PCI and post-PCI OCT, that is inserting a camera inside the coronary artery, and looking at the morphology plaque, that what are we dealing with? Is it a calcified lesion where we need a rotablation or a lithotripsy, intracoronary lithotripsy? What is the exact length of lesion? What kind of stent would you require? What is the exact diameter? Is it going to be 3, 3.5 or 4? And then any dissections being left behind after you deploy the stent, or are you landing in a plaque? You're not landing on a healthy vessel. That is the precursor for medial dissection. What is the apposition of the stent? Is it nicely opposed to the wall? Or a lot of patients would ask you, Doctor, I'm going in a bus, and if I had if I have a jug, can my stent go forward or backward? So that's just an analogy to suggest what apposition means, and the stent expansion is proper or not, which has to do with the long-term prospects of a good angioplasty. So that's called as precision angioplasty, and in this trial it has been seen that the decision was changed in close to 88% lesions if you were depending not just on angiography, but also complementing it with an OCT while you're doing angioplasty pre-stenting and post-stenting. And these are the parameters which is impacted, ranging from morphology to vessel preparation to treatment type, number of stents, length of the stent, diameter, edge dissections, malposition, underexpansion. And underexpansion, as I said, would lead to stent thrombosis, in-stent restenosis in the long run, which is most undesirable. And the lesion morphologies could change in a very large number of cases. If you routinely do OCT, it helps you strategize your angioplasty procedure, that what tools will be required to do the complete job, whether you need a cutting balloon, a simple balloon is okay, or you need a rotablation or a lithotripsy because of the calcium. The lesion bed preparation is very important because that has to do with the expansion of the stent, and it also helps you choose the right length and width of the stent to be deployed in the artery. And this is how, with co-registration, you can exactly know what are the healthy zones where both the edges of the stent should land. Healthy to healthy is the dictum. And angiographic guidance leads to a lot of inaccurate selection of stent diameter, which could be corrected by a pre-PCI OCT, and the edge dissections could be detected in as many as 4.4% cases, where an additional stent will be required, and malposition would be found in close to 11% lesions, where a proper high pressure balloon inflation will be required to give the best end result. Underexpansion could be taken care of by using OCT regularly, and this is again a repetition of slide that underexpansion has to do with stent thrombosis and long-term restenosis. So morphology, length, diameter, medial dissections, apposition, and expansion. That is what constitutes MLD max. And this strategy has in fact been tried in the Indian setting and replicated here also by our lot of colleagues in India and Bangladesh. And this is a simple replication across various sites. That's how pre and post PCI OCT can help you strategize change in strategy, angio co-registration, change in strategy, performing actual angioplasty stenting, doing a post angioplasty OCT, change in strategy, and finally the final result. And this has shown that if you follow this strategy, the results are surprising to the extent that in this trial, the pre-PCI strategy change happened in a very large number of population, and if ACR was added to it, there was not much change, but the pre and post PCI strategy changes resulted into marked change in your strategy, choosing the right stent length, doing post inflation, and thus giving the best ideal PCI result compared to the simple angiographic dependence on your results. So this is a replication of the study which was shown in US, and it was seen that pre-procedural OCT changed strategy in 76% lesions, angio correlation changed strategy about 22%, which is not much, and post-procedural OCT changed strategy in 30% lesions further. So that is the way to go, the contemporary angioplasty change. Thank you so much. I invite you to advise us on the aspects, pros and cons of various calcium blockers available to us in our practice.
So actually, I had thought that you were supposed to speak on it, so I was not prepared any kind of a talk, and but maybe we could, yeah. I mean, what we could just basically discuss about was how do you place the newer generation calcium channel blockers vis-a-vis the older generation ones, and there's such a lot of literature also coming in vis-a-vis the newer ones like penidipine and azilnidipine also. But to find most of our patients and also the Western literature, we continue to see amlodipine only as the prototype which is there, which is followed. In fact, even cilnidipine, which is so much used in our country, especially in the renal patients, is not so much in usage abroad. In fact, very limited, especially in the Western population. So, we have gone through a phase where, especially you remember, sir, there used to be felodipine and lacidipine, etc. which have all were purported to have similar effects and cardiovascular efficacy and benefits like amlodipine. But by and large, amlodipine has been the hallmark and the standard of treatment care pretty much the world over. So how do you place these new, and benedipine and this we know very well are Japanese molecules. So the usage part has not been that prevalent in the West also. So what's your take on them, and how do you actually select either one of them vis-a-vis the conventional amlodipine that we know?
Okay. So, Dr. Sendupta, as much as I am aware, being an old generation, and you two are the old generation physician now, we recall a day when the nifedipine capsules, yellow colored, used to be given to us to control the hypertensive emergencies. We'll just pick up an alpine and poke a hole and put it under the tongue. Well, we were precautious that this should not be the case when you deal with a patient who matter infarction or pulmonary artery disease, because it can lead to infarct site extension by doing so. So the nifedipine was virtually given almost 3 decades ago. And then came these molecules which you have shown, which you told us about. I would just suffice to say that amlodipine is one molecule which is most widely studied across multiple trials. And I have to show you various trials from all hard to accomplish to value and various trials. As far as cilindipine is concerned, it's a very favorite molecule with our nephrologists, and we also use it sometimes. It has half the potency for amlodipine, where cilindipine 10 milligrams to 20 of cilindipine, which we know. We claim that it's probably less than edema or pushing. Well, I am not convinced with that. Not much missing data also. The amlodipine is another of the block which has been added now, especially in combination with therapy. And I don't personally have much experience, and neither would I know the literature about amlodipine. And if at all, there have been stray papers and small observational data on the other calcium blockers other than amlodipine. So as far as I'm concerned, for me, amlodipine continues to be the stable molecule for most of the population, with a caveat that for the pedal edema and flushing and sometimes tachycardia palpitations of patients, where I provide strategy and fallback of non-dihydrocolloid blockers, which I normally refer to diabetes.
So if you have seen pedal edema happening with amlodipine, so we stop it for a while. So if you reintroduce after a while, do you see that it occurring to the same extent, or the patient has been kind of okay with it, stable with it?
Now, my strategy of dealing with it, that as I said in one of the slides, is sometimes a combination of ACE or ARB could counteract the microcirculatory molecule. Addition of diuretic, which it could be a thiazide like or even a high ceiling diuretic, could help reduce the pedal edema and also better control. You may be help come down on dose of amlodipine in these patients if you take help of a small dose of diuretic along with the ACE/ARB. There have been rare times when amlodipine needs to be stopped altogether. One has to look deep into the function of these patients, the protein levels of these patients, and then act accordingly, or maybe bank upon other molecules like the alpha blockers or any other alpha agonist.
Actually, amlodipine is such a potent molecule that when you take it off the treatment schedule, the BP tends to fluctuate pretty much. And cilindipine, as you have mentioned, sir, is important in terms of potency, is almost 1/4 that of amlodipine. And the newer ones, the indications for azilnadipine have not been so much for isolated hypertension, but in complicated cases. So that's. And with benedipine, it's too early to comment on how much it would progress. And personally speaking, I've had very limited experience with this. So thank you very much, sir. I would open the house for comments and questions.
Please.
Yes, Dr. Sendupta, Dr. Popal.
Yes, sir.
Yes, sir.
Dr. Chandra, you said nifedipine is out of the, it should not be used. So still anesthetic very much used in perioperative symptoms. Whenever you're just putting anesthesia, they find that BP is 160, 110, they immediately give dapin. I have heard in one of the seminars earlier also, and I asked them, "What don't give it?" They say, "No, we are using it for last so many years." So they still use very frequently during perioperative period. So what is your advice?
I personally feel, sir, it should be discouraged, and currently there is no place for nifedipine in our practice. In fact, there are various other molecules which are available, molecules like esfolol or enalapril, or even diuretics given to control these hypertensives. And even the amlodipine tablets given to these patients would affect as well within 50 to half an hour. So that practice should be discouraged, giving sublingual nifedipine population.
What is it? Arrhythmia or what?
If the person happens to have underlying coronary artery disease, it can precipitate an event or ongoing infarction. The infarct size has been found in this because of drastic fall in pressure and reduced coronary perfusion pressure. Those are the indications of using sublingual nifedipine.
Can cause coronary disease, so the circulation gets.
Exactly.
So I think you should take a lecture among the anesthetists also.
Sure. We'll do that.
Next thing, you said if you are giving two drugs, compliance will be better if it is one pill. But if you give separately, one in the morning, one in the evening, it will be better covering 54 hours.
Sir, the amlodipine pharmacokinetic says that it is once a day molecule. So you may give 5 milligrams, 10 milligrams, 20 milligrams once a day because it takes care of 24 hours blood pressure control. As far as giving it more is concerned, there is no consensus, and we have to wait for results of science trials. There have been some data saying that if you give it in the evening, it will cause less of fecal edema, less of flushing, and perhaps will take care of the morning surge, which is essential for majority of early morning strokes and heart attack. That is safe, but that concept will be proven only by the data of the science, which is an ongoing chapter on timing of the antihypertensive.
No, my question was, if you are giving amlodipine plus suppose ARB, so one drug can be given in the morning, one in the evening, so that at least you are sure 24 hours coverage. That's what I
could be better. I agree, sir. That could be a better strategy. That could be a better way of doing it.
Yeah. Thank you.
Dr. Sen, can I ask a question, sir?
Please, sir, please go ahead.
All right. Dr. Chandra, sir, the topic was calcium channel blockers. Is old still the gold? Because you had asked me the topic.
Okay.
I don't think you saw the topic, sir. I'm sorry, because I had primed everyone for this topic. But anyway, you had a wonderful talk on hypertension, antihypertensive therapy, and some techniques in PTCA, in CAD, OCD, etc., etc. Sir,
Right.
I'm going to ask you some very simple questions.
Please, sir.
Sir, you mentioned till JNC 7. You didn't mention JNC 8. Any reason for that?
I have actually mentioned ISS 2020 guidelines, and but that takes care of most of the guidelines which have come in past. So as far as we are concerned, that's the latest data given to us, which says that you must reduce blood pressure to less than 130 in age and no less than 120. So that's the consensus, and based on various methods of measuring pressure, office versus home versus ambulatory, the cutoffs are different, and that is the way to do. So that perhaps that is why I skipped it, but that's just a omission which is not intentional.
Right, sir. Sir, I wanted to ask you a question. When we were doing our MBBS and we were third year students, fourth year students in 80-81, we were told the ideal blood pressure is 120/80.
Yes.
In 2021, my question is still 120/80 the ideal blood pressure, sir?
In 21, it is 130 and 80, sir. It could be 120/80, but no less than 120/80. And if you have comorbidities like CKD, diabetes, or stroke, then individuals could still be changed to a little higher side. The sprint data, which says that lower the better, has been fallacious, because the measurement technique in sprint was not accurate. And that led to the perception that the lower the better is the way to go. But that's not the case. So today it is 130 and 80.
Sir, my second question is not related to calcium channel blockers because you have digressed from the topic. Therefore, I am digressing my question from the topic.
Okay.
Sir, in the last about 10 years, there has been a resurgence of diuretics, and there has been a lot of emphasis on the role and effectiveness of chlorthalidone, a molecule which was almost dumped, discarded about 30 years ago.
Yes.
Sir, I want to know your view on the usage of chlorthalidone now in 2021. What should be placed in the anti-hypertensive regimen?
Okay. So that's a very, very pertinent question on this forum. The main debate is between the thiazide-like diuretics, where we have the chlorothiazide and chlorothalidone. Incidentally, chlorothiazide is a molecule which perhaps had the largest scientific data on it in various trials. But when it came to chlorothalidone, here was a molecule which was virtually immune or much less in terms of the metabolic disturbances on electrolytes by using the diuretic. And that is the most desirable effect if you want to use the diuretic, choose a diuretic for hypertension control. Chlorothalidone has an advantage, an edge over the indapamide or even the thiazide like diuretic chlorothiazide. So my take will be that chlorothalidone should be preferred as far as the data is available to us now. But there's a mammoth data behind chlorothiazide also.
Right. Sir, in the same vein, I would like to ask you, in the Hypertension trial, indapamide has been shown to be superior to the other diuretics. So, in the very elderly, should we prefer indapamide as opposed to the other two diuretics?
Okay, so hybrid is a very important data from Spain, which mainly dwells upon the value of paramilitary and the pressure control. Indapamide, Dr. Hong, in my opinion, is a novel molecule. It's not only direct, but it has so many cellular effects that it does with the vascular wall. And therefore, it's also one of the very, very valuable molecules as far as I'm concerned. So, but the only problem with indapamide, it is not a very potent drug or a very potent anti-hypertensive drug. So if you need a potency of a molecule, my choice would be using a 12.5 milligram of chlorothalidone along with an ASARD or a patient. So in a milder hypertension, yes, one can always start with indapamide and look for the control along with lifestyle modification. So it's not only a diuretic, it is a cellular mechanism and has a vascular vasodilator.
Right.
Can I make a small comment, sir?
Yeah, I mean, go ahead.
Yeah. I mean, the other thing, I mean, it's a very oblique kind of a thing, but between the two, you cannot have, decide on superiority because one is an American molecule primarily, the other is a European molecule, and there have been no head-to-head trials. So the only way one can actually take a call on this superiority if there was a head-to-head trial. But other than that, both have been found to be extremely effective and good from the cardiovascular point of view. Would you say that, sir, Dr. Chandra, sir?
Yeah, so if perindopril has to be combined, the third year surveyor would want to pick up their own molecule as indapamide to combine with it. And they're pretty happy with combining with one of the calcium blockers, which is amlodipine, in one of their combinations, triflexen. And if somebody else has to do it, but I feel chlorothalidone is much more potent diuretic as compared to
Also, chlorothalidone was basically the molecule of significance in the all-hat trial, and almost 70% of the authors were again the authors for the JNC7 report. So somehow I feel that the theory and the practice and the practical part also carried on into the recommendations, and we have all validated that, and it's so much in prevalent and good use right now.
Okay, that's news to me. Thank you. So
Dr.
we had some wonderful discussion, and I must apologize to Dr. Chauhan, though I have not strayed from the main topic.
No, not at all, sir.
Right, most of the data and advantages of calcium blocker, and it is still ruling old as before.
Dr. Chandra, can I ask one very simple question?
Yeah, go ahead, Ashok.
Please.
Wanted to know
Please
that
go ahead.
I have any experience that amlodipine causes swelling in the feet for a long use.
Mm-hmm.
Can it cause swelling in the feet after long use?
The pedal edema or prolonged use.
I will not be able to comment because if somebody has to have a pedal edema with amlodipine, it starts appearing as early as within week's time. So I would not be able to say that the prolonged use would lead to calcium blockers, pedal edema. Maybe Dr. Sengupta can touch upon it.
I don't know, I got one experience with the two patients, elderly patients who got swelling in the feet after using amlodipine for a long time.
Yes, it can happen. It can happen. It can happen with amlodipine. And that is why we were always searching for newer calcium channel blockers, with less potential for pedal edema.
And any experience you have got while using sildenafil, it causes it increases the hot flashes which are caused by side effect of radiation therapy.
Especially in patients with CA prostate, is it?
Yes, sir.
Yes, sir. Dr. Chandra, any issue of sildenafil with hot flushes, sir?
Sir, I won't be able to comment because the claim that sildenafil causes less of pedal edema compared to amlodipine, in my opinion, doesn't hold true. And regarding flushing, especially in these prostate cancer patients, I haven't had much experience on this.
Okay.
And one last thing is that chlorothalidone, does it have any effect on the causing constipation?
I don't think so. Some of these molecules have a diabetic, new onset diabetic causing potential or dyslipidemia potential, but this part doesn't seem true.
Sir, any role of S-amlodipine
S-amlodipine, yes. So that's a good question.
in pedal edema?
Yeah, S-amlodipine has the potency compared to simple amlodipine, and it perhaps causes less edema. And I also agree to some extent that yes, S-amlodipine sometimes helps us reduce the pedal edema compared to the conventional amlodipine. I would want to have views together panelists.
Thank you, sir.
Sir, can I ask you a question, sir? Dr. Chandra, sir?
Please.
Sir, in elderly, suppose I get a 70-year-old guy and he has a blood pressure of 170/100, sir. The drug of choice, sir. Calcium channel blocker or a diuretic, sir?
So, that's a tricky question. I would definitely choose a calcium blocker here because the dietary is 100. Because it is unusual for a 70-year gentleman. What we are struggling with in this population is the lower diastolic pressure or white pulse pressure in this population. But in this intact patient, I would choose a calcium blocker to bring down diastolic pressure to below the value of 80. And diuretic I would reserve and use it only to potentiate the effects of other drugs.
Right.
But in isolated systolic blood patient and early, my first choice would be a
Okay. Sir, when we were doing our MBBS in 79, 80s, we were told that in young people with hyperdynamic circulation, beta blockers are the drug of choice. Beta blockers seems to be giving aid to the other group of drugs. Sir, can I ask just your opinion about the role of beta blockers in young people, less than 40 years today?
Okay. So I completely agree that hyperdynamic circulation, hypertensive, high adrenergic surge, beta blockers is the way. And in young population, you sometimes have that flip side of beta blockers leading to little impotence or those kind of things. But that's not very widely prevalent. But if somebody has a tachycardia and hypertension and no contraindication of beta blockers, we definitely pick up one of the beta blockers like nebivolol or bisoprolol these days.
True, sir. Absolutely.
Thank you so much for answering all my questions, sir. So beautifully. I think I have learned a lot from your lecture.
I must thank you. It's most vibrant. The questions were so decisive. It made it very.
Dr. Chandra, one more question. Dr. Pudar.
Yes, sir.
The isolated diastolic hypertension, how common is it? Isolated diastolic hypertension.
Isolated diastolic hypertension, we usually look for a second cause. In person who have pressure of 140 and 100 or 100, we go into the renal functions, ultrasound of kidneys in these ways, urine examination. So that calls for a thorough probe into these. But yes, we do come across some of these patients who have very high diastolic pressure, not too high systolic pressure. But that's not very large population.
No, I know two patients who were having blood pressure 120, 94, 96.
Okay.
So, and they were, whenever blood pressure was more than 90, they were having headaches. I don't know how we can correlate it. And they were started a low dose of beta blocker. For last 20 years, they are very good actually.
Okay. Yes, sir. This is very common observation that some of the patients' baroreceptor system is so sensitive that the moment the pressure jumps up beyond 90 diastolic, they immediately come to know that they have hypertension. And it is advantageous to them that is place for blood pressure checkup and they take few medications. And your case, which you're citing, that beta blocker has this patient, is perfectly fine. But taking calcium blocker to bring down the pressure is the way to go forward.
Calcium channel blocker will be better. Your voice was not clear.
Should be better.
Okay.
Dr. Chandra sir, my last question, sir, my very last question, sir. Sir, I want to ask you, we have the guidelines on hypertension are mostly from the West. Do you think we should have India-specific guidelines? The cutoff for blood pressure in India is different as compared to the Caucasian clique. Your view on that, sir?
Yes, sir. Your point is very, very valid. And as I said in the latest ISS 29, the way it was formulated is the way for the Asian continent of India. Because here the experts which formulated these guidelines were put in from all across the globe, low income, middle income, high income group countries. The emphasis was to propagate blood pressure checkup and control through the nursing staff, through technical staff, because of shortage of medical doctors and professionals. That is the way which has been promoted. If you go into details, these guidelines, and it comes much closer to be applied in the Indian context. But the best thing would be to have your own data, and there have been a few data collections in our own country, like the school data or data from South India in some of the registries. That's the most useful data to have our own guidelines and how the blood pressure should be controlled in our own context, rather than hiring and trying everything from West, which they are commonly doing for.
Sir, can I ask you a very sensitive question, sir?
Please.
Sir, now we see that one of the approaches to lifestyle modification for blood pressure control is a DASH approach, the dietary approach to stop hypertension.
Yeah.
And one of the pillars of this approach is to restrict the sodium intake to less than 2.5 grams a day. Now, since we know that nearly 25% of population is hypertensive, should we not have a policy of only having low sodium salt all across the country? Your view on that, sir? You are one of the opinion makers, the lead opinion makers in the country, sir.
Okay. So, on one point, I agree that the salt intake should be minimized. Anything white, it could be sugar, it could be salt, it could be milk. It has to be restricted to escape the onslaught of cardiovascular disease. But my take on low sodium salt is that my nephrologists have told me that these salts are very, very dangerous in the sense that patients will have unwanted, unasked for hyperkalemia by using these salts. So they would suggest that one must use a salt, isolated salt, and not any other things like the kalanamak or the lona or anything. So I'm personally against prescribing low sodium salt population. They must stick to position of that where the intake should be less than 3 grams per day in our diet.
Thank you. Thank you so much, sir.
Actually, our food is such with pickles and sauces and achars of every variety and papads, which are very sodium dense products that and available all across the country. Even our snacks, etc. Whether you look at a samosa or a buruku in the south, it's all loaded with salt. So absolutely, it's relevant. So that if we don't cut down on salt, that's a huge pandemic which is going on with respect to blood pressure and cardiovascular disease.
I agree. I completely agree with you.
Dr. Sen, if there are no more questions, first of all, I profusely apologize to you for the topic.
We had a very fruitful discussion.
Yes,
I think it was a wonderful discussion, sir, and and Dr. It was a fantastic lecture by Dr. Chandra, sir, and I think we have all benefited hugely from the discussion which followed. And it's been my privilege to have conducted this as a chairperson for a speaker of his stature. Thank you very much for the opportunity.